Thanks very much, Adrian Rufino, for putting on this fabulous course. So I have 5 minutes to make the case for anti-VEGF monotherapy. These are my disclosures. I thought I'd just start, just very quick note about bevacizumab, just because many people are still using this. I just wanted to highlight that there are a few case reports, small case series, but not a lot of evidence for use of bevacizumab. Probably better evidence exists for use of ranibizumab as a monotherapy, at least that in some patients you can certainly see improvements in vision and improvements in exudation. The DRAGON trial probably is the best example of data to support their use. I would say that aflibercept, in terms of the anti-VEGF agents as a monotherapy, probably has the best evidence. And of course, most here are familiar with the PLANET study, where patients after 3 monthly injections of aflibercept were then randomized to, of course, continue on aflibercept, but then randomized to either receive sham PDT or active PDT if they met rescue criteria. And again, patients did very well in the study, achieving good visual gain regardless of whether they were in the sham or active PDT rescue arms. And the reality is that, as you can see by the yellow bars there, most patients didn't require rescue, although those patients in the lower graph you'll see that did require rescue ended up not doing very well in terms, or not as well in terms of their visual acuity. What about comparison between anti-VEGF agents? There have been a few studies, not very really large studies, but have looked at comparisons in terms of outcomes between aflibercept and ranibizumab, and at least in terms of long-term outcomes, the differences were not very substantial. Probably our most potent anti-VEGF agent is brolucizumab, and although we don't have a formal study looking specifically at PCV, there were a subset of individuals in the HAWK trial that did in fact that were recruited in Japan who did in fact have PCV, so that provided an opportunity to study this. And indeed, it was, if you look specifically at that subset of individuals, they can actually do quite well in terms of achieving visual gains, and you can see similar gains compared to aflibercept despite fewer injections. And in fact, a substantial proportion of patients were able to maintain Q12 dosing on brolucizumab, and that's why that's been a popular option. Again, despite less frequent therapy, these patients who were treated with brolucizumab demonstrated greater reduction in exudation compared to aflibercept-treated patients. There have been there's some real-world data as well, so mostly small studies that have shown very nice regression of polyps even after a short loading dose series. This is just to highlight a patient from our own experience who had PCV who actually didn't respond very well to aflibercept monotherapy, but did so to brolucizumab. Unfortunately, of course, with brolucizumab, there is a potential risk. There is an ocular safety issue with intraocular inflammation that has to be considered. So you have to weigh, obviously, if you don't control exudation, you'll lose vision as well. So it's something you have to weigh in the decision-making for these patients. Now, the question often comes up, well, what about faricimab? And of course, we, again, very similar to brolucizumab, we don't have a specific study that has evaluated this, but there was a subgroup, a much smaller subgroup even then compared to brolucizumab, but in the Tenaya and Lucerne trials of patients who did have PCV. And you can see in the small subgroup, to the extent that you can make any observations from a small subgroup, that these patients did demonstrate improvements in vision and reductions in exudation, and you see a substantial percentage of patients, 80% of patients had Q12 dosing or maintain Q12 dosing or better, with a significant number of patients demonstrating closure of the polypoidal lesions greater in the faricimab arm. And I will say that there have been some early real-world experience as well. Again, very early studies because there's not been a lot of experience with this yet, but showing again in the real world there seems to be good regression of polypoidal lesions and good anatomic outcomes at least with regards to faricimab. But ultimately, the good news is we'll actually have better data in the context of a clinical trial. The Salveen trial is currently enrolling patients in 9 different countries in Asia and uses a endpoint in a trial design that's really adapted from the Tenaya and Lucerne trial. So that'll, I think, will give us more definitive information. So to summarize, I think there is good data that anti-VEGF monotherapy can achieve favorable visual outcomes in patients with a PCV. Certainly, I think, as a reasonable starting point. We'll hear about combination therapy in a moment. Not much difference between aflibercept and ranibizumab in the few head-to-head studies that we have. And again, with respect to brolucizumab, I think the data would support that it is a superior agent with regards to anatomic outcomes, but you do have to be wary of these potential inflammatory complications. Faricimab so far looks to be very promising, but clearly we need additional data, which is pending, which we hope to have. Thanks very much.
Thank you, Vas. And next, I'd like to invite Rufino. He will speak on the treat and extend regimen for PCV.